question for you. Do you do melanoma in situ and invasive melanomas? And if you do invasive, any issues that you encounter with that versus with, melanoma in situ?
So we do at the university treat both melanoma in situ and invasive melanomas with Mohs. And I think the place that we, with the NCCN guidelines, it was really exciting to see that we had buy-in from that body in terms of using Mohs surgery. They still recommend staged excisions as the primary treatment, but they do say that Mohs is an appropriate treatment as well for certain sites and places where tissue conservation is important. And there really isn't much in NCCN for invasive melanomas, which I think is why this study is very interesting and important, because really they say more research is needed. And that's why studies like this do help bolster using Mohs surgery for invasive melanomas. I think that the benefit of Mohs is, not only tissue conservation. Some people do take smaller margins, some people do not. They, for example, if you have someone with a lot of pigment in their face, you can't really tell where the melanoma ends and the normal skin begins. I think Mohs can be a big help to patients. We do, the Mohs for melanoma, the invasive ones, if they're just stage 1A, then obviously we just ourselves take care of those. If we feel that reconstruction by outside surgeons is appropriate, that has dramatically improved with Mohs, because when we were doing staged excisions, I cannot tell you how many surgeons we upset because, oh, they're not clear. Now I have to cancel this OR time. We have to find another one. And then we had a lot of our colleagues who just were still confused. We would tell them, no, you can't schedule your repair the next day. You have to wait a week or two. And patients don't like doing that either. So I think one of the biggest benefits for us has just been better working relationship with our colleagues and other specialties in terms of repair, if it's around the eyelid or something large. And we do also do Mohs for melanoma on stage 1B tumors. And in those cases, we will have our head and neck surgeons do the sentinel node the day before their Mohs surgery. So we're not, getting in the way of their, basins for the lymphatic drainage. And then we will proceed with Mohs either, the next day or the day afterwards. And that has really, I think, not only helped patients, but I also think has gotten our surgical colleagues to know who we are. So, this is like a new relationship that we've built with them. And I think it's benefited both of us. Most melanomas come into the institution through derm, whether it's our general dermatologists or in the community. And so now the head and neck surgeons are seeing more melanomas, they're getting involved with them. But, then we also benefit because we can help these patients with the local surgical excision, whereas our colleagues can help with evaluating their lymphatic basins.
I think those are a lot of good points.